Okay, let's continue talking about the complication of the thoracic procedures. So we were talking about pain. So as I mentioned before, pain is one of the common complications. We have to counsel the patient about it, and we have to consider also the chronic pain syndrome. So we have to um, counsel the patient that some patients, rare of patients, might have the pain up to 1 year and rarely lifelong. Um, the post-operatively, immediately post-operative, the pain might cause the patient to have a splinting impact. So patient will try to minimize coughing reflex, the lung inflation, and this will increase risk of retention of secretion pneumonia, and also increase the risk of arrhythmias and thromboembolic event because of the increased release of the catecholamines and vasopressors, and this will increase the risk of these events. Minimal invasive procedures like VATS or RATS or mini thoracotomy will have less risk of pain compared to the thoracotomy. Pneumonia is one of the common complications, not very common, but it might happen after the thoracic surgery. And the mortality is higher in patients with extensive resection, like pneumonectomy or bilobectomy. Decreasing the risk might be achieved with encouraging patient to stop smoking. Patient might be put on prophylactic antibiotics if they have already a risk of or bronchiectasis or and empyema. Those patients are at higher risk of developing pneumonia. Patients also with the sleeve lobectomies should have their secretions cleared and make sure that the low threshold of antibiotics, because we don't want the sleeve to be obstructed with secretions and expose the patient to the risk of pneumonia and ARDS and mechanical ventilation. The risk can be also minimized by encouraging the patient to mobilize early using the spirometry, incentive spirometry, chest physiotherapy. If the patient needs bronchoscopy because of their retention of secretion or unable to cough, um, prophylactic antibiotics in some subset of patients who have a higher risk. There's also we can also do mini tracheostomy if the patient have a retention of secretions during the original flex bronch during the operation. Then we can consider having a mini track to hoover these secretions and decrease the risk of retention pneumonia. The persistent air leak is one of the common complications as well, which happens when the air continues to leak for more than 5 days. One of the risk factors is the patient having a COPD, patient having, particularly patient with lung volume reduction surgery. We expect the lung quality to be very bad and the air is leaking from around the stable line. The length of the stable line is one of the risk factors. Patient with upper lobectomies. If there's an extensive adhesion that was dissected during the operation, leaving the patient with raw area and alveolar air leak. Patient with decortication, with a thick pleura, and when you peel the pleura, you also injure part of the lung, causing a higher incidence of air leak. Patient with massive air leak in day 0 and day 1 are expected to have a prolonged air leak. So what the things that we can do for patient with persistent air leak, we have to counsel the patient with a higher risk and let them know that there is an increased risk of keeping the drain for longer periods, sometimes to get them discharged with a drain and ask them to come back in the clinic. And this had to be counseled with the patient so they already know that there's a risk of something like this to happen. In the patient with persistent air leak, we can apply pleurodesis, either talc pleurodesis, or apply a Heimlich valve or a flutter back, so the patients can go home with this with a drain and mobilize, and then be seen in the clinic when the lung can be up. But this when the air leak is low, we can't apply these when the patient have an air leak of 1 liter, 2 liter. Then we can consider that other modalities of treatment. Atrial fibrillation or arrhythmias are one of the complications as well, around 20%, particularly with the patients having pneumonectomy. The risk factors for the patient having increased age, patient with previous arrhythmias, patient with left atrial dilatation or congestive heart failure. We have to exclude infection. We have also to exclude the electrolyte imbalance, particularly patient having pneumonectomy. Anticoagulate the patient, assess the patient. If they need an echo, we do an echo, and then to consider anticoagulation, prophylactic anticoagulation. Another complication is the empyema and bronchial fistula. So it's not very common complication. However, in pneumonectomy, we have to consider bronchopleural fistula. So bronchopleural fistula can be presented in patient with pneumonectomy if is presenting with fever, tachypnea, tachycardia. If you assess the patient, if the patient have already the drain removed, um, you can assess, you can find that there's a falling of the level of the air fluid level that usually is achieved after the pneumonectomy. If there's a falling of this level, if patient having surgical emphysema, patient becoming unwell, then you have to consider the bronchopleural fistula. If the patient have a drain, still have the drain, there's a massive air leak or increase in the air leak, you also can consider bronchopleural fistula. Patient also might show increase in inflammatory markers. In this situation, you have to put the patient on with a wound up, so you avoid the spillage. Sorry, with a wound down, which is the ask the patient to mobilize, to put the operated side down, so to avoid the spillage of the normal lung, and then ask for a chest X-ray, portable X-ray, urgent X-ray, and then assess that and consider to insert a drain in the pleural space to drain it. Then definitive treatment to be discussed with the consultant, whether we have to close the fistula either with the buttressing the fistula with the pleura, pericardium, sometimes the intercostal flap, and give the patient broad-spectrum antibiotics. The risk factor usually for patient developing bronchopleural fistula following pneumonectomy are patient having previous neoadjuvant therapy, patient with positive margins, resection margins, if there is an excessive or extensive dissection or tension, if the patient have a long stumps, if they are not reinforced stumps. So these are the ones with a higher risk of developing bronchopleural fistula. The middle lobe syndrome is one of the rare but serious complications. It's not very commonly encountered. It's a cause of lobar torsion, so the middle lobe becomes more floppy after removing of the upper lobe. And apparently this happens on the right side, rarely on the other side or with other lobes. Usually it is a middle lobe, it's small size, and it can undergo torsion over its stump, causing a sort of infarction or ischemia. So patient will be developed in a critical state with fever, tachycardia, and when you do an X-ray, you can find the opacification of the operated side. Another syndrome, which is rare as well, is pneumonectomy. So, with a pneumonectomy, there's a fluid filled space that is achieved after pneumonectomy to fill in this empty space or after pneumonectomy. Usually, when it is, or sometimes, there is an excessive torsion over the mediastinal structure, and then the whole mediastinum will rotate toward the operated site. Patient will come presented with shortness of breath and dysphagia, and usually it is managed with filling the space with the prosthetic implants. Then we have a quick chat about the chest drain management, because these are the things that you will usually see in the ward. So these are the drains, the chest drain that you are usually used. As you can see, they can come in different sizes. The one that we usually use is 24, 28. You can even use smaller for draining the air, simple air, and these are usually connected to the tubing, and that will show you what the connection will look like. They have to, either you can insert it through a Seldinger technique or through a surgical chest drain, where you have to make an incision and dissect and can go through the pleural space with your instrument. The other one, which is also commonly used, is called the IBC or indwelling pleural catheter. So it can be inserted by either thoracic surgeon or respiratory surgeon under a local anesthetic, and sometimes we just insert them after doing the pleural biopsy. And we put these drains in the pleural cavity, and they can stay up to 1 year, and they have some part here that keep them in space, and then they can be removed later when the patient has no much drainage, or when if the original cause has been treated. But usually we insert them for the patient with malignant effusion, which we expecting that there would be an ongoing collection. The other ones that we sometimes have we mentioned, if the patient have a persistent air leak, you might send him home or her home on what we call a flutter bag or a Heimlich valve. So the idea of these things are they are connections to act as a one-way valve. So they allow the air to come out, but they don't allow it to go back. The Heimlich valve doesn't have a bag. So if the patient has some fluid, it would be somehow problematic because the fluid will keep leaking because this have, but however, it can be connected to a bag anyways, but it does have a bag that comes with it. And usually it allows the air. This flap here will show you the air flow, so you can make sure that the air is coming out. The other one is the flutter bag. It's almost the same idea where it's a valve, but it does have a bag itself. So if the patient has a collection, then it can go there. And there's a tap which can be evacuated either by the usually the district nurses or the doctors. The most common new type of the chest drain connection. So there are different manufacturers, and depending on which type in your hospital. Usually, as you know, we have these rocket drains, so which are used everywhere in Egypt. But there are other sort of drains. So these drains, you will have a level. Usually, they are filled with sterile water, and this is the connection that goes to this drain. And it is have graded, so you can assess the levels of the drainage. And this column of water is called underwater seal, so it should be reaching down the water, because if the drain has been tilted away, or if the water has been spilled on the floor with a patient or underfilled, then the patient will have the air coming out of the chest, which we should be avoiding. The other thing is also it shouldn't be keeping this type of drains above the level of the chest, because this will cause the air to come back to the chest or the fluid. So you have always to keep them below the level of the chest. There are other types, which are the 3 compartmental drains, or the atrium. They have three compartments for the fluid and the air and the suction. They are not usually commonly seen in Egypt, but you can see them elsewhere. There's also the digital drain, which are appearing sometimes in some centers. These drains are digital drains, so as you can see, they have numbers. So you can assess the number, the amount of the air leak, and you can also show graphs, and you can trace the air leak over 24 hours, and it gives you an idea whether there has been an air leak before. And you can also check the numbers of the amount of the effusion. You can also allow to plot it against time. So it can give you lots of information, and also you can adjust the suction level. So with this type of drains, you have to attach them to the wall suction, which limits the patient's mobility, because every time he goes to the toilet or walk with a physiotherapist, you need to detach it from the wall suction. However, in these drains, you can just move them around, and patient can be totally mobile with them. You can just adjust the level of the suction, and without patients being needed to be attached to the chest wall, to the wall suction. However, they are very expensive and they are not available everywhere. So what are the precautions that you have to take care of while having the management of the chest drain? So first, when you have to check if the patient have an air leak, if the patient have a massive or having a surgical emphysema, which is this spongy feeling of the chest, if the patient usually complain of that, or if you have this imaging and find a surgical emphysema, you have to check that all the pores are inside the chest. You have to check whether the wound is very tight around the drain, because sometimes they might be wider drain than the wider wound than the size of the drain. Make sure that all connections are secure and tight, because you don't want the connection to be taken away, and this will cause the patient to have surgical emphysema. Always make sure that the patient having the drain below the level of the chest. Some patients will just have to carry him going on, moving around, and just carry them on their hands, and they don't take care of it. So it's important to keep them below the level of chest, and always to make sure that, particularly with this type of drains, is to make sure that the water is not spilled, and always this column is underwater. If the patient's on suction, which is not a routine thing or a standard thing as an ERAS protocol, which we will discuss later, just make sure that the suction is properly working. Always monitor the output of the drains. If the patient has a postoperative, make sure that in the very first few hours, you are tracing the amount of the drain, because if they are bleeding profusely and the patient is deteriorating, you might consider to take him back to theater. So this is an important thing. Another thing is make sure that these drains, the connections are not kinked or occluded. Sometimes the patient might fall asleep and then just like put them under their arms or under their legs, and the patient will have, sometimes if they have an air leak, will have developed surgical emphysema, and then you find out that this is already because of the drains kinked or just sitting on the drains. Avoid clamping. Some consultant would say to clamp the drain before removal, but this should be taken very carefully and cautiously, because missing handover of the clamp of drain clamping is very dangerous, and not understanding of the risk of developing a surgical emphysema or air leak or patient having tension pneumothorax is very important. So you have to do this very careful, and by all means try to avoid it as much as possible. And the other thing is also the work drains, as I've said before, filled with sterile water till the level by the manufacturer. With these digital drains, it requires some sort of training, so make sure that you already know how to connect the reservoir and how to use the drain before applying to the patient. Documentation is important for the amount of drainage, particularly if the patient have a decortication or having an empyema, then you would like to assess when to take the drain out. And then you have to make sure that the drainage is less and less every day before taking the drain out. And then when you remove the drain, because you will be involved at removing a drain, you apply occlusive dressing, cut this wound, cut the stitches around the wound, and then ask the patient to exhale and remove the drain and apply the extra stitch if needed. Sometimes just have all these things ready before removing the drain. Ask the patient, explain to the patient what you're going to do, and make sure that you have a chest X-ray requested to assess the lung inflation. It's also important to counsel the patient that sometimes we might need to reinsert the drain if the lung is dropping after the drain removal. These, I think, are everything for today. I'm just going to look through the QE and see if you have any questions. All right. Okay. Thank you. Thank you very much.